Hi everyone, thank you for joining us for another TOTEM talk. Tonight we have Hannah Conway back again, becoming a TOTEM star. Hannah's a cardiac ACCP and a professor in advanced clinical practice with a specialization in echo and a lot of teaching experience in echo. She directs a lot of courses, or at least her own course, G&H, Crit Care Echo, I think, is that right?
Yeah.
And is the national lead for FUSIC Heart, and has been an examiner for FUSIC HD since the first exam. So she's got a wealth of wisdom and an experience she can share with us, or at least that exists for how to get through the FUSIC HD exam. And we had a chat about how we could organise some talks for everybody, and we thought that Hannah would give a talk at the moment on the stuff that people need to do to start reporting scans and getting their logbook filled. And then we're going to have some sessions slightly closer to the exams on how to get through the exams themselves. So thank you again, Hannah, for coming to teach us today. It's a real pleasure having you and listening to your teaching. They've all been excellent talks so far with great feedback. I will hand over to you, and please everyone keep your mics muted. I will try to mute you if you accidentally unmute yourself, and I will put a feedback link on the conversation in about 10 or 15 minutes. If you could all fill that out, fill out your feedback before you leave. Thank you.
Thanks, Samson. Once again, you needn't worry about introducing me too much anymore, because like you said, I'm starting to feel part of the furniture. Yeah, for those of you who haven't met me, I'm Hannah, and today it's sort of one of, I think we've got 4 talks that are focused all around summative assessment, whether that be HD or focused TOE. It's for those of you who are on that pathway and just need a little bit of guidance on how to enhance your reporting initially, and then further down the line we'll talk a little bit about how to prepare for the exam itself, what that consists of, and some tips and tricks from me on how to put yourself in a position to show off your skills. So today's session is focused on those of you who are doing HD, and as with most of the talks I've done so far, I've tried where possible to make this applicable to anyone that might just want to tune in and listen to it. So there will be some sort of general teaching elements in there, and I think really you can apply these principles to any type of accreditation that you're doing. Obviously the intricacies of exactly what we're expecting of you are mainly focused on FUSIC HD, but the principles of how you report and integrate your findings you can apply to any type of accreditation that you might wish to do in the future. So without further ado, let's now go through a couple of the things that I'd like to outline that we're going to cover. So in terms of objectives, I'm talking through this from a HD perspective. We're going to methodically go through the data set initially, so it will act as a refresher as well for those of you who are new to this, and then we're going to look at some of the most common errors that are made, and I'm using my experience not from just HD but also from my experience of a BSc examiner, because they're made by everybody of every level, and I think it's little helpful tips like this that will just kind of make things a little bit more effortless for you when you get to that point of submitting your logbooks. And then obviously at the end, I think the most important thing is how do you integrate all of these findings, because we get to the point where we've written 2 sides of a report and then you sort of run out of steam. And actually what we need to do is bring it all together into a nice succinct paragraph to make anyone else that might come across that completely in the know about what that means for them going forward. So I can see Chamin's just come along. So hopefully by the end of this 45 minutes, an hour, you'll feel 100% more confident to report your scans. So why does that even matter, you say? I mean, is it just because I'm a little bit anal and I want things to look nice when they come to me at the exam? Well, yeah, to a certain point, yes, I am. But actually, no, the real point behind this is because it's really important that we take this seriously. These are, you know, investigations, whilst they don't carry a risk to the patient in the respect that, you know, we don't insert a TOE probe down them and expose them to at risk. We are making clinical decisions based on these findings, and that in itself means that we need to treat it as any other formal investigation and report it effectively. You know, this is not just a tick box exercise, and it sometimes can feel that way when we present to you report forms that, you know, ask you to put reams of data on them. But, you know, there are things that we need to do to critically, you know, analyze those numbers and bring it all together at the end to make some sort of coherent plan. And, you know, from an examiner point of view, we're not there just to look at your technical abilities. Obviously, we design the exam in order to assess that. But given that we don't see your images for that are associated with your report, yes, we could, you know, on the day of the exam, you'll be examined on your practical ability, but we haven't seen you in the clinical workplace and how you manage the reporting of your scans. So therefore, we're relying upon these reports very heavily to see how you synthesize all of this data and then correctly categorize somebody as being normal, impaired, or significantly impaired. And that's really important. So a lot of time is actually spent reviewing these reports to try and get that feel for your level of confidence in reporting things correctly. And it's certainly not just an exercise of you've obtained the 50 minimum required scans that you need for this accreditation. So, you know, utilizing little tips that I'll talk about later about how you can articulate your report. So it still kind of comes across as a nice articulation of physiology and pathophysiology, I think is a skill, and hopefully you'll find that helpful. So getting on to the good stuff, the data set itself. Now, obviously, those of you who are already on the pathway will know that this is available to you on the ICS website, but it's actually also available as open access through the original article that we wrote, whenever that was, 2021, and that was published via JICS. So for those of you who are new to this and want to have a look at what that actually looks like before you embark on it, then you can just type in FUSIC HD and you'll come up with that on the first couple of hits, and it'll be in the supplementary material. And we'll go through that in a moment to see what that looks like. But for those of you who are actually on the pathway itself, then you'll have access to this in your actual learning portal, which is on the ICS registration database. And it is actually not that easy to find. So I just highlighted exactly where it is. It's first of all in the training details part, and then there's a little sign down here which says here is the full HD data set. Now, just a little bit of a sneak preview, we are going to be bringing all the data sets for all of the modules back onto the landing pages, so there'll be open access for everybody, and so hopefully that'll make things a little bit more easy for you going forward. So if you were to look at the data set, you'll notice that the first page or two will be a list of the views, and within that will be the expectation of what you should be inspecting and measuring, and then following that will be a step-by-step process of what views you obtain in what order, and what you should exactly be doing in terms of the assessment. So there's no ambiguity in that respect. This is the minimum data set, remember. I do appreciate some of you might be utilising this accreditation as a stepping stone to doing level 2. So it may be that you are extending your data set beyond this. But when it comes to your logbooks and when it comes to the day of the practical exam, we will only be examining you on this. So it's important that you follow this data set. So I'm going to go with the general way in which we've categorized it on the data set. I'm just going to go through the actual views, not necessarily one by one because we'd be here all night, but I'm just going to go through what specific measurements we're expecting you to report in each of the views, and then we'll come to the end in terms of how I'd want you to report that, or at least how I'd suggest you report it. So the first views that you're going to be coming across, obviously, is the parasternal long axis view, unless you've had issues with this. You know, documentation of this view, even though it's, you know, a relatively straightforward view, you get lots of information from it. And we want you to actually report on both the qualitative and the quantitative, which I've tried to kind of keep color coded as we go through the presentation. So the qualitative stuff will be in the grey boxes and the quantitative stuff will be in the whatever that color escapes me what that color is, bluish, greenish, turquoise, that's it. So with regards to the parasternal long axis view, the main feature of this is the long axis of the left ventricle. So it seems sensible to start there in terms of your estimation of size. You know, ultimately, we still want you to visually estimate. We are expecting you to measure things as well, but your eyeball assessment has by this point, you know, it's your best tool as far as I'm concerned. And I think, you know, when you find something looks dilated and then you measure it, you know, you want to use that as a marker to reinforce your initial assessment as opposed to replace it entirely. There will be some times when there's disparity between those two things. So the first thing we want you to do is estimate the size, and you know, then follow that up clearly here with your internal diameters in diastole. For those of you who are new to HD, you can see here that we're roughly just distal to the tips of the mitral valve in its minor axis. Now here, you want to also extend your calipers into the walls of the septum and the posterior wall, because we also need to assess whether or not there's any degree of ventricular hypertrophy, and you can see that's demonstrated here. And if we then scroll forward a little bit more, no, I've lost the image. If we scroll forward to systole, then what that'll do, as it's demonstrated here, it will calculate your fractional shortening automatically, which is quite helpful because that is a marker of function. Although, as with everything that I talk about when it comes to linear assessments of function, just bear in mind that these are things that should be taken with a pinch of salt, because you're looking at just one line of inquiry as opposed to a global assessment of function. So in one simple caliper measurement across 3 areas, we've got a lot of information there about the ventricular size and function. There are other things that we need to look at, clearly, but I'm not going to focus too much on valves right now because I've dedicated a section to that later in the talk, because this is an area I think probably people are less confident about reporting. I understand that. So we'll dedicate a few slides to that later on in the talk, but clearly this would be the first time that you would assess the aortic and the mitral valve. Now, still in diastole, we want you at this point then to turn your attention to the aortic root, and again, visually estimate it in size. But we also want you to measure it, and here you can see a demonstration of the ascending aorta being measured, and you can see that looks dilated to the eye here. And you know, as you guys should know by now, you're wanting to measure about 4 centimeters back from the aortic valve. We're not only looking for dilatation, we're looking for evidence of flap, and we're looking for evidence of any irregularities within the wall of the aorta itself. So these are things that you should be thinking about as you go through to ensure that you're able to report that effectively when you summarize the section. Next, we're going to be looking at the atrial size, and we always want you to measure the diameters. Now, notice that we're now in systole, so we'd expect you to remember exactly where to measure things in the right phase. This has, on occasion come up as being an issue, but you know, easily solved by just remembering exactly where you should be measuring particular diameters. So atrial diameters should always be in end systole, or when atria is at its largest diameter. And as you can see here, we've just got a nice linear dimension. It's not the most accurate or sort of appropriate measurement personally. I think personally I would always prefer people to do a area or volume assessment, but we'll talk about that as we go through the scan. That's the first time we'd expect you to measure the left atrium, and that will obviously feed in later to your assessment of the LA filling pressures. And then finally, before we move on to the other views, you're going to be estimating or measuring, sorry, the LVOT diameter. Now notice we've moved the cardiac cycle position into mid-systole, or if you haven't got an ECG available, then you want to make sure that the aortic valve is fully open. Now I've put a little asterisk there because it's not actually part of the data set expectation, because it does feature on the data set, but I think it comes with a bit of a caveat here, and this is echoed throughout most of echocardiography, excuse the pun. LVOT diameter, given that it's squared, is obviously filled with risk of error, and as we know, in a setting like critical care, emergency medicine, or you know, acute medicine, the images are certainly poorer than they would be in an outpatient setting, where maybe your LVOT diameter measurements would be easier. So I would personally use your initiative here to decide whether or not it's safer to just use LVOT VTI and use a stroke distance as opposed to a stroke volume. But the only reason to do an LVOT diameter at this stage would be to later be able to then estimate your cardiac output. So do it if you are happy with it, but if you are ever unhappy that you can't see where those insertion points of the aortic valve are, personally I would remove it from the data set, and you can rationalize. You won't be penalized for that. Obviously, as you go through the scan, you're always taking note of any areas that might develop hold collection, and this would obviously feed into your pericardial pleural collection box later on. Your RV inflow and outflow views, really the expectation here is for you to report on the presence of TR, the velocity of that TR, but only to estimate its probability of pulmonary hypertension, not necessarily for you to estimate the PA pressure. And that has definitely been a slight change in the way that we intended the FUSIC HD dataset to steer, and that's really based on the BSc guidelines around pulmonary hypertension. There has been a definite move to not estimating PA pressures and actually utilising it more as a risk stratifier. So that's what we recommend now. It's not to say that those of you who do regularly measure the tricuspid maximum pressure gradient and then obviously add that to a CVP measurement and estimate systolic pressure should begin to stop that. But actually, you know, from a national, international standpoint, that is no longer recommended. I quite like this approach because it leaves less room for over or underestimating. So the only expectation of you would be to measure the velocity max, and then to put that into a category, as you can see here, which I think is a safer approach. And if you were to obviously tilt your probe in the opposite direction, then you'll notice on the right-hand side of the image, you'll see your outflow tract, which you can measure the RVOT dimension. And again, I think for me, this isn't either or, because we're not going to do any velocities across the pulmonary valve to measure RV output or anything like that. But I do think actually measuring the PA or the RVOT is actually quite helpful, because it helps you, again, with your risk stratification of pulmonary hypertension. So that's a really simple measurement to do, as you can see here, and that would be expected for you to report on that. Now, one thing to mention that has come up a little bit is, and I suppose it's because we all have different machines and therefore things get spat out slightly differently depending on what machine you're using, but do take note of what the normal values are that we would express. For example, TRV max, we always express this as meters per second rather than centimeters per second. So just be aware, it's not like the world has ended if you do express it as centimeters per second, but suffice it to say, if you standardize your approach to things, then it will make it far more transferable when somebody else is reading your report in a different department or even in the same department. You know, it's far more safe and standardized to use the same values that are expected. So just take note of that. The BSE app, which I'll talk about a bit later, I'm sure, that's great because it will show you exactly what the normal standard values are for each of these tests that we're expecting to do. Common errors that happen here are just omitting the value entirely. I would probably argue that you should be trying to get a velocity even if the TR jet is minimal, because sometimes the colour Doppler, depending on where it's positioned, may not pick up the jet in its full glory, and therefore you should always try and obtain the continuous wave Doppler through the tricuspid valve to see whether or not you can actually elicit an envelope that you can measure. So do that, and don't rely upon the absence of any TR entirely on colour Doppler being, you know, a guide on not worrying about progressing to do spectral Doppler. And as you can see here, we've plotted our maximum velocity. Our short axis views, obviously, we've got far more levels than we are used to looking at here, and we would expect you to systematically go through these levels, primarily from a regional wall motion abnormality perspective, because that's a big focus of this particular views, and that's something that I would categorically say hasn't quite met the standards that we would expect in terms of the way that you would articulate your assessment of that. Now, obviously, as I said before, there are multiple views, and it's easy to start at the aortic level and then go down. It's not the end of the world if you do it in a slightly different order, but again, it's all about trying to meet that standardized approach. You're less likely to leave things out. So at the aortic level, obviously, we want you to document the position and the movement of the intra-aortic septum. And that's really important in terms of being able to identify whether or not there's any pressure increase on either side of the heart, and document that whether it's in the neutral position or whether it's bowed out to the left or the right. And even as I'm sure by the end of the talk, you'll realise that a lot of what I'm trying to say is that we should be documenting normal findings, not just highlighting abnormal findings. So if it's neutral, then write that, because it's explicit about there being no evidence that you've identified that there's any increase of pressure on the left or the right side of the heart. And that's just as important as you writing actually it's bowed out to the left or it's bowed out to the left to the right. Obviously, this will be a second point in which you can measure your tricuspid regurgitant jet and then elicit a Doppler. So any time that you are trying to elicit the maximum pressure gradient or the maximum velocity, what that really means is that you should measure it in every available view. Even if you think that you've got the best envelope in the world from the previous view, which you may have, it still means that you should measure it in every other view after that point, because the position has now changed. You could get a particularly good alignment with the jet and therefore get a better or higher velocity. Again, thanks to Manoj for lending me these next few slides with the annotations on. So, you know, it's just to really ring home with you chaps that regional wall motion abnormality, it is a really tricky assessment, and obviously we've done a whole talk on it, and hopefully you can use that to help you with that in the future. But the expectation is not for you to go through each segment and write there is no regional wall motion abnormality in the basal anterior septal wall. No, but we would expect you to at least comment on each of the layers to make sure that you are demonstrating that you've systematically gone through that assessment and have identified no obvious regional wall motion abnormalities. And I'll give you an example of how that might look a little bit later. Obviously, pericardial effusion would be commented on throughout the next few views. Obviously, in the mid-papillary level, the additional thing that you would be expected to comment on is the septal wall position. Obviously, this goes beyond just talking about any potential ischemic etiology, and now we're looking at potential pressure volume overload to the right heart. So do comment specifically on if the septal wall. Again, we're not expecting you to identify in a completely normal heart that's got a normal sized RV, but if you've commented that the RV is dilated but it's functioning quite well, that would be an appropriate time to talk about the position of the septal wall, because it could give some clues as to the chronicity of any degree of pulmonary hypertension, for example. And obviously you go down until you reach the apex, and additional qualitative information that might be expected, although you wouldn't be expected to rule it out. But certainly if you've identified the heart to be dilated, significantly impaired, you might want to comment, even though you might not see anything, you might want to comment on the fact that you don't see any evidence of LV thrombus, and you can't rule it out, and you would write that. But that would be an important thing, because really that's what we're trying to look for in the presence of a very impaired ventricle. Is there any risk of there being any thrombus in the lower pressurized areas? Apical views. Now, obviously, these are a point in the scan that you're going to be spending a lot of time measuring. So all the normal stuff we'd expect you to do: ventricular size, ventricular function, valvular assessment, and you're going to be doing a lot of Doppler assessment in these views. Now, for the four-chamber, we want you to document, obviously, the visual appearance of all of those four chambers, and you can then go on to measure. So what we did include in the data set is your RV to LV basal ratio, which I think is really helpful. And as you can see here, that would be an expected norm for you to write that. And again, I would write that even if you, even if the appearance of it was normal. It's important to be able to correlate what your findings are. You've said it's normal, so what's the basal ratio? Does that fit with what you've said? And that would be something that the examiner is actively thinking when they're signing off your individual logbook scans. Other measurements would be, I think I've got a picture for this. Yeah, your LV area. Obviously, this is in two-chamber. It's not expected of you to do that if you've got a good four-chamber view. It's normally where people would measure it, but you can measure it in the two-chamber if you want to. And what I like about this is that, you know, certainly I think in the most recent studies that Shagan did with the Bart's group, is that actually your LA volume has more correlation with your filling pressures than any of the other fancy measurements that we've been using. So actually this is one of the assessments that I would spend more time doing, and I would probably pay this more attention than I would doing the LV, the LA diameter in the parasternal long axis view. It's very easy to do, and I say that, but it depends on what machine you have. I'm sure you've come across these little idiosyncrasies. Now, obviously, all the normal stuff we're expecting you to do, And again, always do it. It's not a case of just do it when you think the TAPSE or MAPSE is impaired. Always report on the TAPSE and always report on the MAPSE. And get into the habit of doing that. I think certainly I'm the biggest offender of it myself. You know, as you get more experience, you do less and less. But actually, at this point where you're presenting this for accreditation, you need to do everything. So actually, more is more in this instance. When you're certificated and you're happy, then I'm sure your scans will take less time because you'll just target it to what you want to know. Obviously, for things like the 5-chamber view, you're going to be now employing your Doppler to estimate your stroke distance, and LVOT VTI. For me, the very if someone just presented VTI, that would be fine. It's not going to be penalised if you have already measured your LVOT diameter and extrapolate a volume and a cardiac output. But again, it's just something to think about. You know, as you're becoming more experienced with echo, you need to be aware of what is recommended internationally. And I think this is probably something that you should take note of, because there is less error associated with this method. And obviously at this point you could also be doing any potential accentuation maneuvers to try and see whether or not you've got any variation. So obviously, as I'll show you again, Samson's lovely electronic form, there's a section for you identifying what the LVOT VTI is, and then a section next to it saying, has there been any percentage increase by you doing a passive leg raise or by doing a challenge with fluid or giving some inotropes or vasopressors. So it's at this point that you would want to document that and be sure to show that variation by using an increased sweep speed, so you can actually see that variation more effectively across more profiles. Obviously, at this point, you would be measuring your aortic VTI or just your Vmax. It depends on which method you use, and you can now extrapolate a dimensionless index. Again, whilst I've talked about the fact that we want you to report on normal findings, I wouldn't expect you to perform a dimensionless index on somebody that had a completely normal functioning valve to your eye. Okay, and that's completely fair enough. But again, it's not, you won't be penalised for performing it, just to get you into the sort of swing of things. But I think it's completely reasonable not to perform a DI unless you feel that there's some evidence from a 2D perspective that would make you worried that there was some degree of stenosis. And then for the 3-chamber view, really, the way I look at the 3-chamber view is, it's required for you to be able to get a global assessment of those regional wall motion abnormalities, but it's also an opportunity to perform your LVOT VTI and your AV VTI all over again if you haven't got good alignment, obviously, with your 5-chamber images. Now, obviously, as we go through these views, I haven't emphasised tricuspid, mitral or aortic valve assessment, but that is definitely expected. And as I said, we'll talk through that in detail. Before we move on to the next couple of views, the last thing we want you to report on is your apical, your LV filling pressures. Now, obviously, this forms a small part of a larger diastolic assessment, which we're not expecting you to do, thank God. And actually, most people in intensive care, if you work in that area, will to some degree have some diastolic impairment just by the virtue of the fact they're on a ventilator and we're doing lots of things to change their loading conditions. But actually, the parts of the diastolic assessment that we are expecting you to do are the parts that do help you estimate your LA pressures. So very simply, we're going to be expecting you to pulse wave Doppler the mitral inflow, and noting that your pulse wave gate is just above the mitral valve on the ventricular side, and we want you to measure the E velocity, the A velocity if it's present. I'm not going to expect you to measure the deceleration time, but for those of you who are doing who are using Philips machines and you're using the calculation package, often what happens is as soon as you place the E velocity, it suddenly gives you the next measurement, which would be the deceleration time. So if that happens, then it's not a massive issue, but you wouldn't necessarily report on the deceleration time because it doesn't factor into your assessment. By doing that, you'll get an E to A ratio, which is obviously down here, and you would just report on the velocities. We don't need you to write anything about pressure gradients. Then you want to switch gears, turn on your tissue Doppler, and we would expect you to measure at minimum the E prime velocity. You don't need to measure the A prime velocity. And if you haven't measured the S prime velocity, that's also not a major problem. It's an either or, but I think it's quite helpful to help with your overall assessment of systolic function if you do this on both the lateral and annulus of the LV, the septal annulus of the LV, to get an average, and also to use it particularly on the RV, because I think it's really helpful as your overall assessment of your longitudinal function. But just note, you won't be penalised if you don't report on that. The main thing is for you to get your E to E prime ratio, because that factors into your assessment of filling pressure. Subcostal views, really important for assessing the pericardial space, and obviously any potential collections that you see, you'll use this view probably preferentially to describe that, and we'll talk about tamponade assessment more specifically in the next couple of slides. Again, an opportunity to look at all four chambers again, but by the time that you've got to this view, you'll have probably saturated your assessment of LV and RV assessment quite nicely. So really, I look at this view as a global view of what's around the heart, but I also like it as a view for the RV wall thickness. And what I'd probably do at this stage is I'd bring the depth right down, or even if you want to use a magnifying box, that's fine, but it won't improve your resolution. So I would reduce the depth down, and you can measure the RV3 wall to see whether or not that's over 5 millimeters. I think that's a really helpful measurement, because actually if you've identified signs of pulmonary hypertension, which this is one of them, it would help you provide a timeline to that. RVH doesn't actually, it takes less time to develop than I thought it did. But it takes time to develop. It's a remodeling process. So it's not going to be present in patients that have had an acute increase in RV pressure. And I think that's a really helpful tool to determine what the etiology of that RV failure or RV dysfunction is. Obviously, you've got your modified aorta views. These can be a pain to get, but at the very minimum, we want you to try and get a look at the aorta at least twice in the chest and once in the abdomen. So you've already looked at the ascending. If you were to be able to do some modified views of the aorta, like here under the short axis, we've got a nice sort of transverse view of it here, longitudinal view of it here, which is very good for looking for signs of flap or irregularities in the wall. But my favourite view is the suprasternal view, and this will be a view that you find very helpful to try and help determine where that flap is, if there is a flap. And also for those of you who work in centres where balloon pumps are often used, then you might be used to determine the position of that with your echo. And those are things that you would be expected to report on. But the basics of what we'd want you to do are, what is the size of the aorta by eye, but also by measurements, and is there any evidence of irregularity in the wall? Is there any evidence of flap? is there any evidence of aneurysm? And as many levels as you can find that information, please do that. And I think, you know, this is probably one of the views that, you know, if you're going to make a life-changing diagnosis, it will come from your aortic views, actually, a lot of the time. So do spend time trying to obtain a good view of these, but we do appreciate that they can be tricky. Your VEXUS views, I'm not going to spend too much time talking about these because we could sit here all day, and I will tell you how I think you should present your VEXUS data. But obviously, the important thing to note is that there's lots of different little bits of information that make up your VEXUS assessment, and that can be in itself quite difficult to put down in a report and then make sense of it. So just try and keep it as simple as possible. You know, we are expecting you to measure for the hepatic. Obviously, you know, the expectation would be that you would only do all of these things if your IVC is dilated. But if it is, then you progress through the rest of the data set. You know, we need to know what the S and the D wave are, and if there is a reversal of it. That's as simple as what we're expecting of you for the hepatic. For the portal, is it pulsatile or is it continuous? And obviously, there's a degree of pulsatility that fits basically before, you know, is it below or over 50%? And that will just help you determine the severity of the congestion. But at very minimum, is it pulsatile or is it continuous? And when it comes to your infrarenal assessment, there's a lot more you can do here. But actually the minimum expectation would be for you to determine if the venous flow is continuous or if there's any type of phasic pattern to it, whether that be biphasic that you often see in more moderate congestion, or if it's very severe, you'll see a monophasic pattern. There are obviously lots of other assessments that we can do, which will involve resistant index, but that is an either or, okay? The very minimum is that you should be able to determine if the flow is continuous or if it's phasic, and to what degree, if it will help you determine the severity. I've put a little reminder here because if you guys haven't read this paper, which is very recent, I think it was 2024, you should. If you're still on the fence about VEXUS in terms of how to do it, it's not necessarily about the evidence base behind it, because we all know that still needs a bit of work. But if you're a bit kind of like, oh, I'm not sure how to read this paper, honestly, it kind of reignited my interest in VEXUS, and it makes it very clear for people. So I talked, that's kind of like a general approach to what we're expecting out of each view, okay, which will help you when it comes to measure it. What I want to do now is spend the next couple of slides just talking about the specific assessments that we need to be aware of and how to report those specific assessments. So when it comes to like stroke volume, it's not enough really just to write down the numbers. We need to sort of bring it all together. So it's also bringing in other parts of your assessment. So here we've got an LVOT VTI that sort of, well, here it's normal, clearly. So we want you to determine if the VTI is normal, if it's varied, and if there's any potential percentage change when you've done any type of maneuver. But we also want you to comment on the function of the ventricle in light of that, because that will give you an overarching context to what potential form of shock the patient might be in. So when you bring all that information together, that section might report like this: LV appears normal with moderately impaired function. The LV VTI is reduced at 14 centimeters. The VTI shows a 10% variation, which is obviously not associated with responsive. So that suggests potentially a fluid intolerance. And the passive leg raise resulted in limited improvement in LVOT VTI, confirming the patient is unlikely to benefit from fluid administration. So whilst that might look like wordy, actually, if that's the key reason why you did that part of the scan, then it it very easily brings together all of that information. You know, it brings together the quantitative assessment, but it brings together the clinical integration as well. And that's the expectation in terms of what we would expect to read, or at least you to verbalize in a setting like a clinical assessment of your skills. The valves. These are the bits that I think most people would appreciate a little bit of a refresher on. The thing with valves is you've got to be systematic. Even if all valves look normal, systematically go through that assessment. Takwa's crying. Why are you crying? Don't cry. Go through this.
The weakest area.
Is it? Join the club. Everyone's had that kind of passage of, it's a rite of passage. And I think what I'm trying to say is simplify it, because it doesn't need to be made as complex as what you think it does. Ultimately, if you find something to look pathological, then you're going to need to have a more formal assessment anyway. So you do what you need to do to determine whether something is pretty normal or if it looks pathological. So this approach, I think, is pretty universal across all valves, plus or minus a couple of things. I think as clinicians that are using this, what's actually more helpful for you is not just saying if it's pathological or normal, is what's the likely etiology. Actually, that's the most important thing to be able to determine. And also, once again, bring back that old adage, make sure that you determine if something's normal, you need to write the assessment that has allowed you to make that that overall diagnosis. So mitral valve assessment, using a little example here. This is a patient, obviously, who's got a very impaired left ventricle, which is at least on the mild dilatation, but I think it ended up being moderately dilated. I can't remember now from my memory, but there is a mitral regurgitant jet. Now, to just say MR present would not be sufficient, because it doesn't tell you what the likely etiology would be. Whereas actually, when you've commented on the LV function as well and the size, all of a sudden the etiology becomes a little bit more obvious. This is likely, because it's centrally directed, to be a functional MR as opposed to a primary MR. I appreciate you can't make that assessment just looking at it now, but the integrity of the valve itself was pretty normal. It was mildly thickened, but the mobility was good. There's a mild to moderate centrally directed jet of MR, which affects under 50% of the left atrial area. The reason I've done that is because that is the expected range for a jet that falls under the severe category. Okay. So whilst you might think, well, why are you writing that extra bit of information? It's because it really helps me categorize where that severity lies. And, it's a bit tricky, because we're saying to you guys, we only want you to determine if something's normal or very impaired. But naturally, as you do this, you'll start to get a feel for what fits in those grey zones. And I think this is a really good way of helping categorize things without definitively putting them into a mild moderate category. Aortic valves, what we're really wanting to ask here is what's the morphology? Can you determine if it's got 3 cusps or not? And if you can't, then you will report that, but the expectation is that you'd be able to determine that. So here we can see a trileaflet aortic valve. It's got moderate commissural thickening, which it might not be terminology that you're used to using, but it's really helpful, because actually it's helpful to then match that to a likely etiology. Commissural thickening is something that occurs in a normal degeneration of the valve, as opposed to maybe having asymmetric thickening that might be more mobile, then leads you down a slightly different path, doesn't it? So actually, when you talk about an equal distribution of thickening across the commissures, then already I'm thinking, well, that's normal degeneration as opposed to something more sinister. It's got normal mobility in light of that. The calcification isn't bad, and there is a little bit of it, which we can see here. And I've gone to the extent of writing where that is. again, that's kind of gold standard. You're not going to be penalised for not writing that, but that might be information that would be helpful down the line when they look at this valve again in a couple of years. And obviously, we don't measure AR in the short axis windows, but it'd be helpful just to comment on that as you're bringing together your aortic valve assessment, whether or not there's any regurgitation on colour Doppler. And I think we've talked about tricuspid valve assessment already enough, but it's just to hone in on the fact that, again, if there is a normal tricuspid valve with TR, the expectation would be for you to always follow that up with a velocity and then suggest where that risk of hypertension fits in that category. Okay, low, high, or intermediate, or probable is the way that it's written in the guidelines. And obviously, as you can see here, we've got colour Doppler to support that. I better get my wriggle on. Now, filling pressure assessment. We talked about how to do it in the last few slides, but in terms of how to report it, then again, don't just report the numbers that you've collected. Bring it all together. First of all, the LA looks massive here, so that's the first thing. You know, your pre-test probability of there being a high LA pressure is already high. So, you know, features of raised LA pressure present are, you know, bringing together our ratio, which is obviously high. We've got an E to E ratio of 18, which suggests a high LV filling pressure. Our LA is enlarged. Write the diameter of that. Talk about any potential pressure that has been exerted on the septum and how that moves over the cardiac cycle, and then together bring in that and put in, you know, these all suggest significantly elevated LA pressures, and that's the expectation, because really I can, without having watched you do the scan and seeing your images, I know exactly that you know what you're doing, because you're bringing all those information and bits of puzzle pieces together, and you've made the correct overall assessment of that. Tamponade, well, again, it's a bit of a dodgy one, because obviously if this happened and the patient's unstable, there's no expectation for you to stand there and write all of this out. You know, after the fact, when something's been sorted out with the patient, it's important here to determine what the echocardiographic features of tamponade are, rather than talk about it as a clinical as this being the only tool of diagnosis, because we know that not to be the case. But the things that we're looking for are where the actual pericardial effusion is. If it, first of all, is it present or absent? And if it is absent, write that, because that's important for you to report. Describe the size of it, small, moderate, or large. The distribution, circumferential or localized. The echogenicity is important, because that might give you some clues as to, you know, the contents of that collection. And then measure the actual largest diameter at different points is important. The bigger things here are the echocardiographic features. So, is there any RA systolic collapse? Is there any RV diastolic collapse? What's the respiratory variation that you can measure with your mitral inflows? And is there any dilated and fixed IVC? And that's how you'd bring together that whole assessment. And that's really the crux of it when it comes to tamponade assessment. Venous congestion, as I said earlier, can be a tricky one, because it feels like you've just measured loads of stuff, and how do you now put that into a nice, neat box? Well, really, you know, if you wanted to just write the numbers in the actual body of the report, and literally a couple of sentences for each waveform. So the hepatic veins show a diastolic predominance with the ratio. The portal vein shows increased pulsatility with the pulsatility index of 70%, and the infrarenal vein Doppler shows a monophasic pattern with D wave below the baseline. Really, the summary of that is that you've got multiple features of significant venous congestion with the Vexor score of 3. So whilst that might look like a really complex assessment to go through, which it can be tricky, the overall sort of summary of that is quite short. So I think getting your head around that and realizing the actual effort to do it sometimes with the outcome is a bit of difference between the two, but it is a helpful assessment. So I'm going to leave you with some best practices, which hopefully these will be the parts of the video when it goes onto the YouTube that you might go back and have a look at before you submit your reports. So using the template that Samson has provided for us, thank you, Samson. Important to recognise that these are bits that you might have just skipped over. Don't, is what I'm saying. Obviously, when you're sending things in, we can't see patient details. That's completely obvious. But don't skip over this because this is really important. So give some context. Make it clear what it is that you're looking for, because actually we use that information as examiners to then be able to say, well, have they answered that question at the end? Because that's the whole point of doing the report, right? Is there any confounding factors? You know, the patient's on high oxygen requirement, they're on, you know, slightly higher ventilatory pressure. Has that had an impact on maybe their RV findings? You know, these are things that we'd be looking for, and we'd be looking for you to be able to make that correlation as well. So these are things that you should spend time doing, and especially if you've got support on, we do need to know that. I'm not going to go through every section of the report, but using the LV section as an example, this would be the expectation of somebody who, you know, has got a normal LV by size, normal wall thickness, but the function is impaired, right? So the visual, we're not expecting you to measure the EF, but you can visually assess it. Now, when I say visually EF, it can be a tricky one. I would advise that you use the categories that BSc use in order to define what is normal versus, you know, severe, for example. And obviously we're calculating the fractional shortening, so we can use that as a calculated measurement. MAPC is a calculated measurement, we can put that in. When it comes to regional wall mesh abnormalities, if you've seen any abnormality, then reduced thickening, and you can actually follow that up with hyperkinesis as the overall, you know, description of that particular segment. If you don't see any regional wall mesh abnormality, then write that. So normal wall thickening and excursion. Okay, it might be like, oh God, do I have to do that? But actually, yes, because we need to know that you've assessed that part of the LV. And here I've just wrote that there's been little change, in fact no change, but there was some inotrope response. So again, you know, little fine-tuning things like this can take what is probably an excellent scan, but we've only got face value, a report to look at, and therefore, you know, do make these small changes because they make a huge difference to we you know, us as examiners being able to say, yeah, that person knows how to report, they've covered everything, and they've been making this the correct overall assessment because the numbers match the descriptions. In terms of the final 10 questions, don't leave these out either. It's really important that you get these in. Because this is the whole point of HD. You know, the whole point was that we were trying to use these 10 questions to help you just determine your management of the patient. So I would definitely make sure that you fill all of these out, and do use free text as well. You know, this is why Samson wrote this column, because it helps. Because, for example, if you've seen, is the aorta abnormal? Well, if it's not, then how is that? You know, if it's abnormal, then okay, fine. But maybe write it's normal in appearance without any dilatation or dissection flap evident. It just fine-tunes the report and makes it clear that you took notice of that particular part of the exam, and it's not ended up becoming a quick tick box exercise. But obviously it's more important that if you determine something is abnormal, then what have you used as an indices to determine that? Here, VTI, that's all I've used to determine that stroke volume is abnormal. Now, one thing that I would say on top of this, and again, if this is all that you have done, because that's the report is done, you know, as far as the expectation, but I personally would use this box here to write how you've integrated those findings. Okay, so if we use that example, this now for me just rounds off the entire report. So the findings are consistent with septic cardiomyopathy, moderately impaired LV, reduced stroke distance, elevated LA and P pressures indicate diastolic dysfunction with increased filling pressures. There's moderate venous congestion with a lack of fluid responsiveness, suggesting the patient is on, I mean, you don't have to go to the extent of writing all of this, but this is taken from actually one of my reports, I think. And I personally like writing this because I think it gives really helpful information for people that maybe not au fait with echo, and then immediately, you know, without reading the whole report, they've got a whole box here of really helpful information that directly leads them to what's going on. And then I provide a recommendation to what we should be doing. Okay, and I think that's how we should be reporting HD scans, because the whole purpose is to bring it all back to what are we going to do next, rather than just providing a report for a clinician that's then going to start making decisions. It's you that's going to be doing this, and this is why I think it's helpful to round it all off. So it would be remiss of me not to talk about a couple of pitfalls which might give you some help before I leave you tonight with regards to preparing your reports now ready for exam. There are some highlights here from previous exams, but also from my experience in the BSc arena. Common reasons why things get rejected. So incomplete documentation. So if we look at your whole report and you've left blanks there, it might be that you've not performed that because the image quality wasn't good enough or whatever, but we don't know that. That's just all assumption. We just think you've not bothered. So you have to make sure that you rationalize why you haven't done certain sections of the report. Okay. If it's technically challenging, I'll give you some examples on what you can write in that instance. Vague descriptions aren't really acceptable at this stage. You've gone to the extent of doing a scan, which is going to take about half an hour. So go to the extent of writing down exactly what you've seen, because that's really helpful for people who are looking at your images after the fact. So rather than just saying normal LV function, or sorry, just poor LV function, which is often what we see on reports, write significant impaired LV systolic function with a visual EF of below 35%. If you've got a fractional shortening, even better, because we can use that as a marker of improvement or indeed deterioration. And then write down the other things that have made you fit that patient into a significant category, MAPSI, and the fact that they've got global hyperkinesis. That's far more appropriate than just writing poor LV. And I think I've hammered this point at home already, but always report the normal findings as well as the abnormal findings. That's just as important. We need to know that you know how to report normal as well as abnormal. And be consistent across your reports. So when you get to the point of wanting to put yourself forward for the exam, have a look at all your reports and think, are they consistently reported? Because that will stick out like a sore thumb to us. Naturally, the earlier reports probably are going to be a bit shaky because you are early on in the process, but we need you to be consistent with how you report, and I think that will help you as well in terms of being able to just get into the swing of things. And the big thing really is failure to actually answer the clinical question that you've asked of the scan. And it might be that you said it's a training scan, but try where possible to ask a clinical question so that you can actually then summarize the report by answering that question. I think that's really a nice way to present your report. If you've had technical issues with this whole process, here's some examples of how I would expect you to address that. So, for example, if you have had suboptimal views, you might want to write the plaques view was suboptimal due to body habitus mechanical ventilation. but also write down what you've been able to assess from that. So even though it's limited, you have been able to get visual estimation, which is better than no estimation, because you've, that old adage, no views, so no assessment. We can't really get away with that. But you've sensibly said you've chosen not to take the measurements of the chamber because the image quality wasn't good enough. That, for an examiner, that's like music to our ears, because we're like, that's sensible. That's an appropriate course of action. If you have really struggled throughout the whole scan, maybe write a sentence to describe what issues you've had and what you've tried to overcome that, because there will be instances where you've had a real mare of a patient in terms of scan, and you might not have been able to fill all of those boxes. And instead of just trashing that off as a case entirely, actually, if you were able to articulate why you've had issues and what you did to try and overcome that, that still might be appropriate as a logbook case. Obviously, not all the time, but on some occasions. And I always think this is good etiquette, just outside of an exam setting. What if you were able to achieve an image after doing all of these, maneuvers? Where did you achieve it? Because that just helps the next person. And I think that's good etiquette personally. And you'll find it if you read a lot of the cardiology scans, they'll write that quite a lot. They'll say the aortic views are not in the normal position. Aim for this rib space. Yeah, that's really helpful. And I think, again, just to put home that you should always identify if you've put down that you've not been able to achieve apical views, and therefore there's going to be lots of blanks in your assessment. Have you been able to at least assess the parts of the HD data set that we're expecting of you? Because if you haven't, then that might not be a scan for your logbook. Okay, and that's kind of sounds obvious, but sometimes it isn't, and you do have that internal dialogue where you're like, oh, can I still submit this as a case? Well, if you can't answer the clinical question with the degree of missing information, then no. I think that's a discussion to be had at the time. And in that case, for example, here, you could then, summarize that in the real world by just saying that we need a comprehensive echocardiogram to look at certain sections of the assessment that you failed to address, for example, the valve assessment. So I think I'm a couple of minutes over, so I do apologise, but I know this is a topic that people do like to spend a bit of time talking about. Now, in terms of the key takeaways, I won't read these out to you, but I think you've got it by now. If you've got a system, it'll work 100% of the time. Okay, this is all reporting is. You've done the scan, you've done the hard bit. Just have a system whereby you can ensure that you don't miss bits out. The big thing I want to say, and I know that you'll probably laugh at this because I know it's an old adage with doctors' handwriting, but there is something to be said about using the electronic form, because there's no ambiguity then in terms of what you've written. If you aren't using that, then that's fine. I'm not suggesting that you suddenly have to start using it, but please make sure that you look at your reports after the fact and make sure that you can read, or at least give them to somebody else and ask them, can they read? Because we have rejected logbooks because of legibility. So that's just something to think about, because we don't want you to have to go through the process of resubmitting stuff. Anything you haven't taken away from what I've already said will be in the data set, which is available in those locations we've spoken about. As I said before, I can't talk highly enough about Samson's reporting form, and this is now recommended as well. I'm sure Ashley Miller and Samson have had long chats about this. This is definitely a recommended, approved form for FUSIC HD, and Echocalc. I am its biggest fan. It's a very good little pocket friend, just to make it clear where your categorization should fit. And if you haven't got it, you should download it. So that's it, guys. You know, I know that it's frustrating being in a virtual environment, but do ask questions, because I don't need to rush off. And if you've got some burning questions, then I'm very happy to answer them before I go today.